Okay, so here's your syllabus for OEM 207. Congratulations on getting through pathophysiology and intro. We'll roll on into pharmacology. It looks like we'll be spending most of the month in pharmacology here, and these dates are just a little off. And we'll take a look at the schedule, and it has all the new dates and homework assignments and all that. So. Prerequisites, all the objectives, the major things that we will be focusing on throughout this course. There's a whole laundry list of them. Your guys' outcomes, what we're going to be expecting from you guys.
Administration of medication, that's going to happen?
Yeah, believe it or not. Yes. Yes. Believe it or not. Everybody has a textbook, Pharmacology for Pre-Hospital Professional, the revised edition 2010 by Dr. Guy. There we go. All the phone numbers are still the same grades, 80% and above to pass, 94 and above for an A. All right. We'll have labs. There'll be some quizzes. All right, 80% minimum. There will be a exam. May not quite be 100 questions, but there'll be multiple choice. And this particular, what we will be doing is, because there is a national registry skill that is directly associated with pharmacology, there will be a national registry skill station that we'll have set up that you guys will do as a part of your final as well. But everybody in here is an intermediate, so you've all done this or something similar to this, so shouldn't be a huge deal for you guys at all. Basically, it's the IV and IV bolus medication station, which is something that we'll be working on in lab as well. So it's not a huge deal. Sometimes dosage calculations can kind of trip people up a little bit, but we'll get through that. All right, so all the same classroom stuff. If you think you may have a disability, there's where you go. And here's our schedule, and this is the most current schedule that we have. It may change a little bit depending on how things are going. You know, like I said, we're ahead just a couple of days, so we have some flexibility if we need to spend more time doing stuff. So here's today. So your first set of drug cards will be due on the 30th, which is Thursday. And we'll talk about the drug cards, or we talked about them a little bit. I'll talk about them a little more as well. And then we move on in to next week. We'll be doing a lot of hands-on stuff in the afternoons. This Thursday, most of the day will actually be hands-on. We'll do live sticks. Generally, we don't do live sticks right away, but everybody here is an intermediate. Everybody here is pretty much working out in the field. I don't really see the need to have you do 10 IVs on an arm, an IV arm, before you do live sticks. We'll just go right into live sticks. And anyone here have an issue with needles? A little bit? Okay. Thursday might be a rough day for you.
I'm taking that day off.
It might be kind of rough because we'll be doing IMs, subcutaneous injections, and then intradermal injections as well. And yeah, we'll do IOs on each other too. What the heck, yeah. All right, so there you go. This is just additional syllabus information like we've seen. You're definitely welcome to go through it. And there actually will be a little quiz that will pop up over the syllabus next week. Here are your important dates as far as transferability statements and all bunch of numbers here. And withdrawal attendance policy. Okay, cool. So that's that. Any questions over the syllabus or the schedule, or in general kind of how things will run with this particular class? Is everybody pretty much okay? Cool. Okay, so what we're going to do is we're going to start off and we'll ease into pharmacology. We'll talk about some of the introductory stuff here. I have a little PowerPoint that I actually made. And then this afternoon I'm going to go in and we're going to talk about the finer points of some of this stuff. It will not be a PowerPoint presentation, however. It'll be on the board, and I have some notes for you guys. And this afternoon might get a little complicated. And so I'll be very specific on the things that I want you to focus on, because there will be some things that I'm going to do to demonstrate. Okay, I'm going to demonstrate some pathways and demonstrate how things work, but I am not going to hold you accountable for remembering all that stuff. And there are very specific things that we will, but these aren't any of them. All right, so here we go. This is your introduction to pharmacology. So I like throwing this picture in here because this is just kind of an interesting, it shows how things around the world are a little differently. So this is actually, we're in the back of a Russian Antonov airplane. This is late 1940s, early 1950s airplane flying over Iraq somewhere. We're coming out of Balad. This is a patient who had a hypertensive emergency and ended up blowing a aneurysm at the base of his brainstem called a Berry aneurysm, had a subarachnoid hemorrhage. So obviously I had to take the patient out there, but he had an intraventricular catheter placed in his brain in order to monitoring his intracranial pressures. And he was kind of going downhill, I'll be quite honest. Things weren't going very well for this particular gentleman. So here I am, and I'm setting up a infusion of a beta blocker, because this patient's blood pressure is like 250 over 180, or just huge, massive. He's really hypertensive. We hit him with Tylenol suppositories, give him a little bit of fluids, and so I'm setting up a infusion of a beta blocker to try to knock the pressure down a little bit.
Did you say you gave him Tylenol suppositories?
Yeah.
For fever?
Yeah, he had a really high fever.
Okay.
Yeah, he had developed a pneumonia. So he had bilateral pneumonia and loss of secretions. So he ended up having to manage his airway as well. I mean, it was a very complicated flight, and it was a 6-hour flight. We flew him from Balad to Dubai. Balad was in Iraq, and Dubai is in the United Arab Emirates. So we came out of Iraq and then just basically flew down south, right along the Persian Gulf and into Dubai. So it was pretty tough transport. What I thought was interesting, though, is this guy right here, and you see he's got a syringe in his hand, and he's doing some dosage calculations in his head. He's drawing up some medications. Who do you suppose this guy is here?
Medic.
Okay, yeah. I think you'd say, hey, this is a paramedic, yeah, right? You know, that's how things roll in the United States, right? 2 paramedics or a nurse. In this case, you know, I was a nurse, paramedic. Actually, he's a physician. And I thought it was just so interesting working overseas that our primary partners were physicians. And here you have physicians that are there helping you package patients and drawing up meds. And you don't ever see that in the United States, do you? Have you ever run into that? It's really interesting. So I thought it was really cool. This guy, his name's Dr. Ashton Bakkenpool. He's a South African emergency physician. He's actually in the South African military now. But anyway, so just kind of interesting pharmacology aside. Okay, so let's get into pharmacology. So what is pharmacology, first of all? That's a reasonable place to start. What do you guys think? Sure.
Study of medications?
Yeah, so it's a study of drugs. And I'm going to use the term drug and medication synonymously. Is everybody okay there? Some people have it in their mind that drug means something different, like drug is, it's illegal or bad. No, a drug equals medication. So I'll use those 2 words in the same context. So specifically what we're going to be looking at in pharmacology are the different interactions that occur between things that are alive, living organisms, and chemicals that affect normal or abnormal biochemical function. Okay, so when we give medications, we are affecting our patients at a chemical level. That's ultimately what's going on. And so unfortunately, or fortunately, depending on how you are, we will be revisiting a lot of that chemistry that we talked about in the beginning of pathophysiology. Lots of different things go into pharmacology, how drugs are made and their properties, their interactions, how they're used therapeutically, their medical applications, okay, fighting diseases, pathogens, and toxicology. which is kind of near and dear to my heart because I've been in grad school for the last 2 years studying toxicology, specifically clinical toxicology in detail. And toxicology is just nothing more than pharmacology, but the dose is a little different. That's all toxicology really is at the end of the day. Okay, so just some basic terms. So what we call therapeutics. This is just a study of how we use drugs to be therapeutic, how we use drugs to treat problems. Pharmacotherapy is the application to treat a specific disease process. So you can see that there is some, these are very closely related. These two words, don't worry so much about therapeutics and pharmacotherapy. These two words are critically important, and a lot of what we're going to do today, we're going to spend diving into talking about these two words. These two words are pharmacodynamics and pharmacokinetics. So pharmacodynamics, okay, get a way of remembering what pharmacodynamics is what the drug does to the body, okay? That's pharmacodynamics. What does a drug do to the body? Okay. It is a study of the interaction of chemicals with biological receptors, but those chemicals are doing something to the receptors in the body, and they're doing something to your body. Pharmacokinetics, however, the ghetto way of thinking about pharmacokinetics is what your body does to the drug. So what the drug does to you and what you do to the drug. And ultimately, it is pharmacodynamic and pharmacokinetic processes that determine the ultimate pharmacology, to determine what's going on with an agent when I give it. Specifically, pharmacokinetics can be broken up into several different components, and we'll talk about them in more detail. The absorption, distribution, metabolism, and excretion or elimination. Okay, but before we get into that, let's just talk about where drugs come from. Okay, they come from lots of different places. They can come from plants, right? Atropine, for example, medication atropine comes from the belladonna alkaloids. Okay, that's a plant. Drugs can come from animals. We used to get insulin from animals, right? Farm animals, right? We'd grind up their pancreases and we'd extract the insulin. We now get insulin through what's known as recombinant DNA technology, and a big part of that uses bacteria, believe it or not. And what we do is we take a bacteria and we reprogram bacteria to produce different substances that we want. And even crazier is we actually can use viruses, so we can engineer a virus, and that virus can contain a gene that when it infects the bacteria, that gene will tell the bacteria to manufacture some substance or some drug or something that we want. So we're doing some really incredible things with viruses and bacteria. It can come from minerals as well, right? Salts, okay, like sodium chloride, lactated ringers, all those ions come from minerals. Chemicals that we make in lab, and obviously recombinant DNA technology. In the United States, this is a big point here, the FDA, the Food and Drug Administration, regulates drug testing and approves the release of new drugs. And drugs can go through several different phases of testing, right? And you start at what's called phase 1 trials. Have you guys ever heard of that term before, phase 1? So we generally start at phase 1, and phase 1 generally involves animals. And so I'm going to test these on animals, and I'm trying to determine the toxicity and safety profiles of these drugs based on what happens in animals, and then I try to extrapolate those findings to humans, and there's a whole field called allometric scaling that we use to try to extrapolate, which sometimes it works well, sometimes it doesn't. But once we try it out on animals and we have some reasonably well-informed idea of how safe or unsafe the substance may be, then we move up into what are called phase 2 trials. And phase 2 trials is when we use the medication on limited numbers of patients, okay? Limited numbers of patients that have the disease that we're trying to treat. And what we try to do with phase 2 trials is we're trying to determine if it's safe and effective in human beings and what kind of dose. This is where we figure out, okay, what kind of dose do we want to go with? Once we get through phase 2 trials, then we can move on to what are called phase 3 trials. And these are what we call the large, multi-center, blinded, double placebo-controlled clinical trials where it involves thousands of patients. Your patients are blinded, the researchers are blinded, you have placebos sometimes, and you're trying to figure out, is this effective in large populations? And once you make it through phase 3 trial, then what happens?
Release it.
Yeah, then what happens is if everything goes well, you know, and this can take a decade or more to get through from phase 1 to 3, the FDA will make the decision based on all the evidence that you've gathered. Yeah, okay, you can bring this to market. And then finally, there's something called phase 4 or post-market surveillance. And that is where just because a drug makes it to the market, does that mean we stop studying it? No, yeah. You continue studying it because there are problems that can occur that may take several years that we don't know about and that you don't pick up on phase 3. Like, for example, the COX-2 inhibitors, the Celebrex and Celexa, some of the pain medications, we're now finding that there may be an increased risk of cardiovascular disease and strokes in patients that take those particular agents. But that didn't happen until years. You know, people had been on those and they've been out for years. In fact, we're now finding a medication that you guys give a lot of may have some issues associated with it, and that's Zofran or ondansetron. Have you guys heard about what that issue might be? Yeah.
It doesn't work.
It works in some patients. It's actually, Zofran was designed as a chemotherapy. It was designed to help people that were getting chemotherapy with nausea and vomiting. So Zofran works much better with medication-induced nausea than other types of nausea. So sometimes you'll see you give it, and like if you have like motion sickness and things like that, Zofran may not work very well in those particular situations. But what we're finding is Zofran can increase the QT interval in some patients and can make them prone to developing torsade de pointe or sudden cardiac death as a result of torsades. And again, you know, Zofran's been out there for a while. So it took us a while, post-market surveillance, to find these problems. So where do we find information about drugs? And you guys definitely need to know this because you're going to be doing lots of drug cards, so you need to know where to go to get information. Now, luckily, you have a textbook, and most of the drug cards, you will be able to get that information out of the textbook. And the textbook is really nice. Has anyone started reading through it?
Yes.
What's at the end of every chapter in the textbook? I really like it.
Drug cards?
Yeah, kind of like a drug card. You actually have complete profiles of all the drugs that were covered in that chapter, and it has a picture of it, and then it gives you the pregnancy category, the dose, the contraindications. So all the information for your drug card is right there. So that makes it really handy to have that in your book. Okay, so yeah, different drug guides. How many people carry little flip guides with them when they're out in the field? Some do, some don't. How many have them on their phone? A lot of them do. Do you actually use them on your phone?
Yeah.
I find
look up something about the drug.
Okay. I find I'm not pulling my phone out a whole lot when I'm running calls because I don't want to get stuff on my phone. So I find that I don't use my phone as much as I thought on mine. Are you guys familiar with something called the PDR, the Physician's Desk Reference? Basically what the PDR is have you guys have opened a medication for the first time, right? A new med? And what's inside of the package there? What kind of falls out?
A pamphlet.
Yeah, it's this like little crinkle up pamphlet and you open it up and it just has all this jargon in it, right? That's known as a package insert. That is information that comes directly from the company. And basically that's what the PDR is. A PDR is a big book full of package inserts, okay? So that is a place you can get some information. Different guides. Hippocrates has become very, very common. Probably most of you or a lot of you guys have Hippocrates. If you don't, I would strongly recommend you throw it on your phone, both Android and Apple devices, and it's free. It's completely free. And you can have all the formularies and thousands of medications, really helpful. Some of the hospitals have programs like Micromedics. We talked about field guides, drug guide books, textbooks. Is there a possibility for bias in some of these sources? Yeah, and I'm not saying that there is definitively, but when you look at the PDR and you look at package inserts, that's stuff that comes directly from the company. So you have to take that into consideration. And so what is considered the true, definitive, non-biased source of information for drugs in the United States? The USP, the United States Pharmacopoeia. How many have ever accessed the USP or have access to the USP? Yeah, okay. Not many of us are working in a pharmacy where we have access to the USP. But with that said, excuse me, it is considered the ultimate quote-unquote and bias-free source for agents in the United States. Okay, so let's just talk about naming real quick. So drugs have different names, all right? They have chemical names. Okay, hopefully you guys are able to identify a chemical name. Right? If it has words that are hard to read and it has 3s and 5s and 8s and 9s in there, okay, that's a chemical name. Okay, it describes the chemical structure of the drug. And we're not really going to focus a whole lot on chemical names so much because that's not as relevant to what we do here in EMS. You will have to be able to differentiate between the generic and the trade name or the brand name. And what's a quick, easy way of differentiating between generic and brand?
The generics are lowercase.
Generics are lowercase and brands are uppercase. Okay, so brand name is the company. Okay, it's a company puts their name to that. They develop that medication. They put their name on that. And then they have the rights to distribute that under that name for so many years, right? When that gets approved. And then what happens after so many years?
It drops off.
Then it drops off and they no longer have proprietary rights to that. And then other companies can begin making it, but those other companies cannot distribute that under the trade name, rather they have to use the generic name. Does that make sense? For example, Bayer aspirin. Bayer is a trade name, right? Whereas aspirin or aspirin is the generic name, and then acetylsalicylic acid would be the chemical name. Does that make sense there? Cool. All right. There's also something known as the official name. And this is the official name that everybody can agree on is the name for a certain medication. And the easiest way to identify the official name is there will be a USP after that name. So, for example, diazepam USP, or United States Pharmacopoeia, is the official name for that particular substance, diazepam. Everybody agrees. Is everybody okay with that? Cool. And in lots of cases, the official name will be the generic as well. But there you go. Okay, clinical pharmacology, yeah, how it works, what the classification of the drug is, and we'll talk about different classes as we go through. Indications and uses. So when I say that there's an indication for a drug, what that means is the FDA has approved an agent to be used for a specific condition. Does that mean that we cannot use that agent for other conditions? Not necessarily. And there is a term known as off-label. Have you guys ever heard of that? Off-label use. And some medications have unofficial or off-label indications. But those are not indications that are officially accepted or approved by the Food and Drug Administration, the FDA. So, contraindications. So when I say contraindication, do I mean you can never ever use an agent? No. It means that there is a risk-benefit analysis that you have to take on. Does that make sense? And you have to go, okay, do the benefits of giving this outweigh the risks of the complications? Okay. So contraindications are warnings about what's going on. They're precautions. And there are situations where the patient may have an adverse outcome. Something may adversely happen. Now, there is a special class of contraindications known as absolute contraindications, and what does that mean?
You definitely don't.
You never give it. Under no circumstances. Awesome, you guys got this. Cool. Okay, interactions. This can cause some headache for people. Okay. Patients often receive multiple types of medications, and those different medications can interact with one another. And we'll talk about the basic interaction terminology. Okay. So first of all, the easiest to understand is the additive interaction. Okay? And that is to say the effects of the medications add up. And I like to think of this as 1 + 1 = 2. All right? So if I give a medication, let's just say I give a medication that relieves 1 unit of pain. All right? Let's say that that medication would decrease my pain from a 10 to a 9. You guys good with that?
Yeah.
So imagine that medication A here can decrease my pain from a 10 to a 9. And then I give a different medication B, which could also decrease my pain by 1 unit from a 10 to a 9. What would you expect if you gave A and B together?
An additive interaction.
Right, my pain would go from a 10 down to an 8. Does that make sense? The effects add. Okay, they add up. So if I give 2 milligrams of morphine and then another 2 milligrams of morphine, okay, I have an addition because I'm giving the same medication. But we know that there are medications that are similar to morphine where they can have effects that are roughly additive. Okay, now we move into the more complicated interactions. The first of which is synergism. Synergism is, if you give the 2 drugs together, there's a greater effect than either of the drug could do alone. So let's kind of talk about this. So let's say that I have a situation where I have drug A, and that drug A has 2 units of pain relieving properties to it, okay? And I have drug B, and drug B has 1 unit of pain relieving properties to it. What would you expect if I gave A and B together? You would expect 3 units of pain relief. Are you guys okay with that? But let's say that when we give these together, instead what we get is 6 units. 2 + 1 = 6, okay? So there is what's known as a synergistic reaction that occurs when those 2 drugs are given together, where the outcome is much greater than you would anticipate. Does that kind of make sense? Okay, it is not just a simple additive effect that happens. The ultimate outcome is much greater than the sum of the individual parts, if you will. Is everybody okay with that? And then finally, we have something known as potentiation. Potentiation is where, and I'll just give you a situation. Let's say that I have an example where my drug A, okay, drug A has 2 units of pain relieving effect. And then I give drug B, and drug B has 0 units. Drug B is not even a pain medication. It doesn't have anything to do with pain. What would you expect the outcome to be? You expect 2 units, right? But instead, I get 4 units. What in the heck just happened there?
So how is that different from synergism of
Synergism because they're
Because
both
pain?
pain meds.
Okay.
Yeah, but the ultimate effect is much higher than you'd expect. Yeah. In potentiation, the second medication has nothing to do with the first as far as its effects.
Okay.
But when you give them together, you have this enhanced effect. And I imagine that you guys have probably done this and maybe not even known it. How many people give Phenergan or have given Phenergan or promethazine or Zofran? Okay. And how many of you have given that with morphine or fentanyl maybe? Okay. Now, believe it or not, there is a potentiation reaction that occurs when you give antiemetics and narcotics, or opioids, we'll say, like morphine and Phenergan. You actually get enhanced pain relief when you give those two agents together. You actually get enhanced pain relief, and the pain relief is much greater than than if you just gave the morphine alone. Does that make sense? Now we know that promethazine really doesn't have anything to do with pain, right? Doesn't have anything to do with pain receptors. It works in completely different receptors, but the interaction of those two medications being given together enhances the ultimate outcome. Does that make sense? So I think of potentiation as 1 plus 0 equals 3. Okay. And then synergism you can think of as 1 plus 1 equals 3. And then additive effect is just 1 plus 1 equals 2. All right. Is that clear as mud?
Yes.
Sort of. All right, cool. All right, adverse reactions. So these are unintended side effects. They happen. They can be mild. Lots of times they are. They can be mild all the way up to very, very severe and life-threatening. Right? Tremors, bronchospasm, headaches, hypersensitivities, etc., etc. What is a severe allergic reaction that involves bronchospasm and angioedema, and airway compromise, hypotension?
Anaphylaxis.
That's an anaphylactic reaction, yes. Now, what should you do if someone says they're allergic to a medicine, quote unquote?
What happens when you take it?
There you go, yeah, okay, what's going on? Because a lot of patients think they're allergic to things when in fact they just had some sort of adverse reaction, right? You get morphine, you get a little itchy, right? Some people may think, oh, I'm allergic to morphine. Well, we know morphine causes a histamine relief, and that can make a release, and that can make you a little itchy. So that's just an adverse reaction. But instead, they say, oh yeah, they gave me this antibiotic, and my throat closed up, and they had to put a tube in my neck for 5 days. Okay, okay, we got it. All right, dosage administration. Yeah, we know that standard dose. How is it supplied? Okay, and the route of administration. Okay. So how do we administer medication? What are the two, before I get into all this, what are the two general routes of administering medications?
Oral.
Even more general than that.
Enteral and parenteral.
There you go. Enteral and parenteral. What's enteral? What's an enteral route?
In the mouth.
Well, even more general than that.
Through the liver. I mean the kidney.
It gets absorbed in the GI tract.
There you go. Enteral means that you have GI absorption. So the absorption occurs through the GI tract. Okay. So if I give something by mouth, that's enteral. If I give something down a gastric tube, would that still be enteral? Sure. If I give something up the hoo-ha, right, up the rump, like a suppository, is that enteral? Yes, it's all enteral as long as you have GI absorption. And then you have parenteral. What does parenteral mean?
Outside the G.
Outside, right? Or alongside. And what are our common parenteral routes?
Topical?
Topical is kind of in a category all by itself. Yeah, you might consider buccal parenteral route through the gums, or some people might consider it more enteral because it's part of your GI tract. It's a little fuzzy there. What are some solid parenteral?
IV, IM.
epidermal, intranasal. Yeah, might fall in there. There's some ambiguity there. ET2 might fall into there as well. Okay. And then you're going to have these other routes like topical, dermal, that don't necessarily fall into either of these categories. If you had to pin it down, these topical would be more parenteral though than enteral. Is everybody okay there? Mm-hmm. Now the reason that we talk about parenteral versus enteral has to do with how drugs are metabolized, and we haven't even talked about metabolism yet. But when a drug gets absorbed through my GI tract, where's the first organ that drug's going to go to? The kidney? Goes to the liver, right? So your mesenteric circulation for your intestines dumps into the liver. So if I take a medication orally, or enterally we'll say, the first organ that medication is going to hit is the liver. And one thing you definitely want to know for pharmacology is the liver is the metabolic powerhouse of the body, okay? A majority of drug metabolism occurs in the liver. So what's going to happen is the first organ that drug is going to encounter is going to be an organ that is going to metabolize the drug. Does that make sense? So that drug is going to get changed very early on in the process. And that is known as the first pass effect. Okay, the first pass effect. And that first place that absorbed medication is going to go is to the liver, and it's going to get metabolized right away. If I give a medication parenterally, however, I inject it into a vein, where's the first place that medication goes?
Heart. Brain.
Or just throughout the body, right? It gets distributed throughout the body, and it doesn't go to the liver right away, does it? So if you want to bypass the first pass effect, you want to bypass the liver, the metabolism, you give something IV. And there are some drugs that have to be given IV because the metabolism of the first pass effect will deactivate them or break them down. They won't work. For example, okay, yeah, adenosine. I was thinking something that everybody is maybe familiar with, epinephrine, right? Right. Have you ever heard of squirting some epinephrine down a gastric tube to a patient in cardiac arrest? Right. Put a tube in their stomach and squirt some epinephrine into their stomach. You ever heard that or seen that
I've seen that done.
Huh?
I've seen that done when they didn't get the tube right.
Okay, yeah. Maybe you have some bleeding and squirt some epinephrine on the blue. But have you ever like, hey, give them a milligram of epinephrine gas by mouth? No. How do we give the epinephrine? We give it IV, right? We give it IV because if you were to swallow epinephrine, okay, you may have the epinephrine may have some effects on the mucosa, but what's going to happen is that epinephrine is going to get absorbed through your intestines, and you have enzymes right there in your intestines and your liver. Specifically, you have an enzyme called monoamine oxidase, or MAO. We talked about that a little earlier. And that MAO enzyme is going to break that epinephrine down before it gets to the rest of your body. So that epinephrine won't have a chance to get to your heart or your vessels where you want it to go. So, choosing to give a medication orally or enterally or parenterally is actually a really important consideration. And it has to do with that first pass effect. Okay.
So just curious, if they were on MAO inhibitors and couldn't break it down.
They could potentially get some more absorption. And we see this, people do this with certain drugs. Have you guys ever heard of a drug called N,N-dimethyltryptamine, or DMT?
Oh, yeah.
It's a psychedelic drug. What people can do is, generally you cannot eat or swallow DMT because of all that mal in your gut. So what people will do is they will actually take MAO inhibitors so they can ingest the DMT, and more DMT will make it into their brain and give them a more profound experience. So yeah, absolutely. Okay, so enteral routes, GI tract, right? We know oral, okay, sublingual, gastric, all right. What's MPO? Nothing by mouth. Okay, gotta give it rectally. Tylenol, for example. All right. We know our parenteral routes as well. All right. Now we'll talk about the pharmacokinetics of the drug. Okay, so we talked a little bit about the introductory stuff. Let's go ahead and talk about the pharmacokinetics. Remember, the big picture pharmacokinetics is what the body does to the drug. Is everybody okay with that? What does that body do to the drug? Now, pharmacokinetics is a mathematical basis to assess the time course of drugs. We're not going to dive too deeply into the mathematical basis of the kinetics, however. Okay? Some of you here have taken chemistry, right? And you remember half-lives and decay constants in chemistry? It's that exact same mathematics that we use in pharmacokinetics. So if you like logarithms and decay constants and that, you'll be right at home when it comes to pharmacokinetics. We're not really going to use much of that. We will talk about the half-life and some other things. Okay, so pharmacokinetics helps determine how much of a drug gets somewhere. Okay? If I swallow so many milligrams of a drug, how much of that drug is going to get to where it's going in my body? We use pharmacokinetics to figure that out. How long is that drug going to stay in my body? How often do I have to give a drug? We know there are some medications that we have to administer more frequently than others, right? For example, epinephrine. How often are we administering epinephrine in a cardiac arrest patient? 3 to 5 minutes, right? How often are we administering, let's say I give somebody 10 milligrams of morphine. Am I administering 10 milligrams of morphine every 3 to 5 minutes? No. The pharmacokinetics between those two drugs are very different, right? And that determines how much and how often we give them and how effective a specific dose is. All right. Pharmacokinetics is a field that can be broken down into 4 different concepts or components. Atom. Just think of atom. Pharmacokinetics is atom. Absorption, distribution, metabolism, and elimination. Okay, so pharmacokinetics starts when that drug hits your body. How is it absorbed? Once it's absorbed, how is it distributed throughout your body, and how does it get to where it needs to go? And then we'll talk about how is it metabolized, and there is kind of a newer word that we use in pharmacology to talk about metabolism. Because what is metabolism? When I say metabolism, what is the meaning of metabolism?
The body breaks it down.
So just metabolism in general. The actual definition of metabolism is the sum, that's just a sigma, that's a Greek sigma signal, it just means out of everything. It's the sum of all of the chemical reactions in the body. So that's literally what metabolism means, the sum of all chemical reactions in the body. Well, that's not very helpful because when we talk about metabolism, we want to focus on drugs, right? We want to focus on drug metabolism. So there is a newer word known as biotransformation. Okay, biotransformation is the newer word that a lot of people are using to describe metabolism. So if you go here in 8-9 months when you guys are taking your boards, if you see biotransformation, you should just automatically go, they're talking about drug metabolism. Does that make sense? Biotransformation equals drug metabolism. Okay? Like we said, pharmacokinetics is what the body's doing to that drug. Okay? So you absorb it, it gets distributed where it needs to go, it gets metabolized, and then finally it gets eliminated. Does that make sense? Is everybody okay there? So we don't use pharmacokinetics to determine how the drug is acting on receptors in our body. We're using these to determine how does it get in, how does it get circulated around, and how does it get out and deactivated. Okay, so absorption. Let's just start absorption. All right. So prior to systemic absorption, a drug needs to be disintegrated or dissolved. Does that make sense? For example, if I manufacture a ball bearing as a drug, and I swallow a stainless steel ball bearing, is that going to be a very effective drug? Why not? It's not going to get dissolved, right? It's going to stay a ball bearing in my stomach, and hopefully if it doesn't get stuck somewhere, it'll make its way through my intestines, I'll poop it out. Not a very good medication, right? So I need to disintegrate and dissolve the medication. So this makes sense that if a drug is already in solution, it's probably going to get dissolved or absorbed much faster. Does that make sense? So if I have, say, a capsule, and I swallow a capsule that has to be dissolved in the stomach, or I swallow some liquid, which one would you think, on the average, is probably going to get absorbed faster? Probably the liquid, right? It's already dissolved. It's already going to get absorbed faster. Okay? All right. So we talk about the enteral routes. Yeah, we talked about these already. Your enteral route is generally going to be faster or slower absorption-wise. Slow absorption. What about inhalation? It's going to be pretty quick, right? If I inhale a nebulized medication, that's going to be absorbed through the lungs, right? And where do the pulmonary veins go? To the heart, right? So I'm going to have pretty quick systemic delivery of that medication, which may or may not be a good thing, depending on what it is. All right. Okay, so if I give a medication IV, am I even worrying about absorption anymore? No. I pretty much bypass the absorption process, right? I give it IV, and it is in the systemic compartment, like that. Okay. If I give it IM or sub-Q, is it bypassing absorption, however? No, because it's still going to take time to absorb in that tissue and get into the vascular compartment there and then get distributed around. Is everybody okay with that? Okay, cool. Now, absorption is going to differ a little bit depending on how you give it. You can give what's known as a bolus. What is a bolus? Let me give a bolus. There you go. A large amount in a small amount of time. Does that make sense? So I give you a bolus of something. So if I give you a bolus of something, will that medication get into this central compartment very quickly? Yes. So you would expect the concentration of that drug to get very high, but then what is going to happen as it gets metabolized and eliminated? It's going to drop down. So when I give a medication by IV push, okay, I'm going to see something like this, where the concentration goes up and then down, and then up and then down. Does that make sense? If I give something via a continuous infusion, okay, and let's say that I'm increasing the dose on that infusion, I'm titrating the dose up, I'm going to see something that's just going to kind of gradually rise up like that. Does that make sense? Okay. Some medications, what we have to do is we have to give a bolus to get them up to that desired level, that therapeutic level. So I'll just draw it here. I have to give a bolus, and then what happens after you give your bolus? What do you need to do? You start a maintenance infusion. So you give your bolus, and then you start your maintenance infusion to keep them at what's known as the steady state concentration. We see this with medications like amiodarone, okay, in our cardiac arrest patients, right? We give 300 milligrams IV push. Don't worry, we'll be talking about amiodarone and other things in more detail. But you'll give it as a bolus, and then you start an infusion after you give a bolus to keep them at that level. Does that kind of make sense there? Cool. All right. Just some other words. The therapeutic range. So this is the range of concentration in the body where I have a desired response. So if you go back to these little graphs I drew here, So this here on the y-axis is the concentration, and here's the time. And let's say that the range for this medication is between this concentration and this concentration, like that. Is everybody okay with that? So if I can keep the concentration of the drug with this range, it will have its therapeutic effect. If the concentration of the drug gets above that range, we have problems of toxicity. And if it gets below that range, then we have problems with it just not being effective. Does that make sense? Everybody's okay there? I'm going to stop here because bioavailability I want to spend a few minutes on. So take a little break, and I'll see you guys in about 10 minutes.